What I will start with is reviewing or describing anorexia nervosa and bulimia nervosa using the DSM-V criteria, but really emphasizing the psychological characteristics that are in some ways so unique to these disorders. I'll speak about epidemiology, risk factors, detection and prevention, and spend most of the lecture on the assessment and evidence-based treatment for these eating disorders. And I'll spend a brief word on prognosis. The hallmark symptom of anorexia nervosa, simply put, is that patients don't eat enough. They don't eat enough food compared to their metabolic requirements, which can actually be quite significant in young teenagers and children. Because they're not eating enough, they end up with a low body weight, often very markedly low. Not eating is due to fear of weight gain, and it drives several behaviors. Again, restricting, meaning cutting down on the food you eat, or fasting, going for 8 hours or more without eating. Some patients might cut out a few hundred calories. Some patients might go down to 1,000 calories a day, 800 calories a day. I've had patients eating 200 to 500 calories a day on admission. Exercise can often be compulsive, with patients exercising many hours a day, sometimes in addition to their sports that they do at school. And this can be an addictive symptom that can very much complicate their care and treatment. While the majority of patients with anorexia start off with restricting and exercise, a majority end up with some type of binging and or purging behaviors, purging most commonly by vomiting, sometimes by laxatives, enemas, and very rarely by diuretics. Patients may also take appetite suppressants. The most common is caffeine. Second most common are the psychostimulants used to treat ADHD, and sometimes patients will go and get herbal remedies or diet pills from the pharmacy. Really want to emphasize the psychological characteristics of anorexia nervosa. These patients have a distortion in the way they experience their bodies. It might be a global distortion where they look in the mirror and see something much bigger than is. It might be localized to concerns about their thighs, their stomach, their arm. Whatever it is, it's incredibly distressing. And unfortunately, even though patients might successfully restore to a healthy body weight, the body image distortion does not, at least at first, get better and can be incredibly distressing going forward and complicate their recovery. This is the words of a patient. It's an actual quote of a patient refed to a healthy thin weight, and the way she experienced her body. "I feel like my body's not me. I feel like I'm wearing a fat suit. I'm a beached whale. I have a picture of a beluga whale on my phone because that's what I feel like." And they have to eat, even though they feel so badly about their bodies. I also want to take a moment to emphasize the mindset. What goes on in the mind of a patient with an eating disorder? There's preoccupations about weight, shape, food, calories. They end up spending a huge amount of time thinking about it, often withdrawing from their other activities and causing an extreme amount of emotional distress. Turning now to bulimia, the hallmark symptom is binging. Binging is eating a large amount of food. Patients will describe starting eating and not being able to stop. Binging might be 3,000 calories, it might be a couple pizza pies, it might be day-old goods from Au Bon Pain. It can have binge episodes where patients binge and then purge. Sometimes patients binge for days at a time. In any case, it's incredibly distressing because they're concerned about weight gain, and then they have to do things to try to prevent weight gain. The most common is purging and restricting. Restricting, cutting down on what they eat, so very common, especially in the adolescent population. Patient gets up, does not eat breakfast, goes to school, does not eat lunch, comes home, tries to avoid eating their snack. Maybe they eat their snack, maybe they binge because they start eating their snack, or waits, eats dinner with the family so the family doesn't know what's going on, and then ends up binging and purging at night. So binge-purge cycles with the binging causing weight gain, which causes a redoubled effort to try to lose weight. Patients might also exercise and again take appetite suppression. Some patients take enemas, laxatives, and very rarely diuretics. These patients have to binge to meet DSM-V criteria at least once a week for 3 months. They also have body image concerns, and it does not occur during episodes of anorexia nervosa. So again, the majority of patients with anorexia nervosa have some type of binge purge behavior, and if they're underweight, they meet criterion for anorexia nervosa binge purge, which actually is important from a medical standpoint because purging at a low weight is the highest risk of medical mortality. I'll speak about this later. Again, psychologically, these patients also have body image distortion. They look in the mirror and they don't accurately reflect their own body. They're also dissatisfied with their weight and shape. They also have the mindset with a lot of thinking about food, weight, shape, eating that really preoccupies them and causes a huge amount of distress. And very importantly, they're often ashamed about their purging and, as many patients say, failed anorexia. And they often, as patients say, don't look as if they have an eating disorder because their weight is often at or above ideal body weight. And so they're embarrassed and ashamed about their weight and their inability to lose weight. How frequent are eating disorders? In 2007, Hudson et al. From the Harvard School of Public Health published the National Comorbidity Replication Survey, and actually the lifetime prevalence of anorexia nervosa in that survey was about 1%, 0.3% in men, a little bit more frequent for bulimia nervosa at 1.5% and 0.5% in men, but very important that there's much more subsyndromal anorexia nervosa or bulimia nervosa, patients not meeting criterion from the DSM-IV, this is now in the time of DSM-IV, for anorexia nervosa or bulimia nervosa, but have a clinically significant eating disorder. Of note, the new DSM-V criterion are more liberal, and we will be diagnosing more patients with anorexia nervosa and bulimia nervosa because of that. Mean onset, also coming from the National Comorbidity Replication Survey, is adolescence for anorexia and slightly older for bulimia. Other studies have showed a mid-adolescent onset for anorexia, with bulimia having somewhat of a later onset. And very importantly, bulimia may come out of anorexia nervosa. So again, a patient starts off with restricting, exercising, losing weight, sometimes coming to pediatric attention, and everyone's saying, you're developing anorexia, you need to gain weight. Patient will go, start gaining weight. Everybody will breathe a sigh of relief and say, goodness, thank goodness, they pulled out of their eating disorder, only to find out that the patient has started to binge and purge, and they now have bulimia nervosa. So again, restricting anorexia evolves into bulimia nervosa or anorexia binge purge, with a small percentage of patients maintaining a restricting anorexia nervosa. What are the risk factors? What causes eating disorders? First of all, we wish we knew more about what causes eating disorders, because if you know what the causes are, we can hopefully focus our efforts on prevention of eating disorders. I will make an attempt, based on what we know, to talk about risk factors and potential methods of prevention. But I want to say two things. First of all, it's not one thing for one patient. What causes the pieces of the puzzle are very different in individual patients. We also know that there's biological or environmental, psychological, and social etiologies for eating disorders. Starting with biology, there's moderate evidence of moderate to substantial heritability. There's a very good study going on right now called the Anorexia Nervosa Genetics Initiative, where we're hoping to get information from genetics to find out what potential candidate genes might be contributing to familial cases of anorexia nervosa. We know that there's an increased risk of eating disorders if there's a family history of eating disorders, obesity, or mood disorders. And so in some ways, based on that risk factor, a prevention might be to screen more carefully for eating disorders in patients with a positive history of any of those eating disorders, obesity, or affective disorders. I want to add a couple of examples from animal research. There's a huge amount of research going on right now in animal models trying to elucidate the hunger-satiety feedback loop. Hunger and satiety is a very complex mechanism involving multiple brain regions multiple areas of the body with multiple molecular signals, and we're trying to elucidate it again in lower animals so that we can get some clues about what goes wrong in anorexia nervosa. One of the animal models used is the activity-based anorexia nervosa. In this case, rats are put in a cage. First, they're given free access to a running wheel and regular access to food, and then their food intake is severely restricted. And what you see is that these rats restrict their intake even more and increase their running wheel access and have rapid and severe progressive weight loss. Based on that, one can extrapolate is perhaps we should try to avoid dieting in female athletes who have high metabolic requirements. I've clinically seen this many times where you have your swimmer who needs an extra 1,000 calories a day, who tries to cut down a little bit on the eating to improve the health of the eating, and they end up in the spiral of anorexia nervosa. So an idea from the primary science that potentially could be translated into primary care. Animal model of bulimia nervosa, basically rats are put in a cage, given restricted access to standard chow and intermittent access to a highly palatable diet. Usually in the rat world, this is either Sara Lee's New York cheesecake or it's corn syrup mixed with cream. And what they find is because of the restricted food access, the animals will binge when they're given the highly palatable diet. And in many ways, the treatment of bulimia nervosa is to get patients to eat regular food on a regular basis so they don't get set up for binging on highly palatable food. I'll speak more about the treatment of bulimia nervosa later, but again, taking from the animal models. We also know that there's psychological risk factors. Unfortunately, a significant minority of patients have a history of trauma, sometimes severe childhood sexual abuse. A majority of patients have a comorbid psychiatric disorder. So we see a lot of major depression, some bipolar disorder, significant amount of anxiety disorders, generalized anxiety, OCD, social phobia, and a lot of low self-esteem and low sense of low self-efficacy, even in very successful patients. And perhaps given these risk factors, a prevention or intervention could be a mental health referral for any patient with a history of trauma, self-esteem, or comorbid disorders. We also know that patients who have a history of early puberty have an increased risk of eating disorders. We don't know whether this is biological, whether it's the impact of estrogen, or whether it's psychological. I'm including it under psychological just because young girls whose bodies develop before they're emotionally ready to feel like a woman might have a self-esteem impact. But just putting it on the radar screen and monitoring the impact on self-esteem. Patients also with a history of peripubertal obesity are at increased risk for eating disorders. This is complicated because of the problem of obesity in the pediatric population and the desire to intervene and treat obesity. But what we know is that the majority of eating disorders stem out of a diet, and some of our patients develop eating disorders in the context of saying, my doctor told me to lose weight. In many ways, the prevention for a patient who has obesity around the time of puberty is either careful dieting. Careful dieting might entail having the entire family improve their eating habits to fairly healthy eating habits, not extreme or restrictive eating habits, but just fairly healthy eating habits, and increasing activity level of the family at whole and seeing what happens. Or if the child or teenager has a lot of stress going on, maybe watching and waiting and putting the problem of obesity on the list of things to do when things improve in the life of the child or adolescent. Social environmental risk factors include modeling. Some sports promote a drive for thinness. On the bright side, many coaches, instructors, teachers have now been educated about this. I've had I've had patients who come in who do crew who say, number one, her crew instructor said, her crew coach said, you're not in the lightweight boat, you're in the open weight boat, number one. Number two, your weight has to be above 140 or you're not rowing. And it was incredibly helpful for that patient to know that their coach recognized their eating disorder and said that they would not allow her to row in the context of an eating disorder. We also know that there's a large number of media images which glorify a thin female ideal, but there's also growing public awareness about this, and that family stress can play a role. Historically, when I was in training, I was taught that anorexia nervosa was caused by an angry mother and an absent father, often the mother being angry because the father was absent. That's a stereotype, might be true in some cases, but it's actually way more complicated than that. Regardless, there's often significant family issues or family stresses that worsen or promote eating disorders, and family education and family therapy can be incredibly helpful for these patients. Turning now to assessment, in many ways, the first job of a pediatrician in eating disorder is to find out that the patient has an eating disorder, because it's often don't ask, don't tell. Ann Becker, who's the director of the MGH Eating Disorders Clinic, did a study in primary care settings and found that patients with eating problems, only 50% disclosed to their primary care physician. However, of the 50% that didn't disclose, most said that they would have told had they been asked. And so what we do is want to look for clues and ask questions. What questions might you ask? I would say things like, do you ever make yourself sick after you eat? Do you ever find yourself eating a large amount of food that makes you uncomfortable? How's your body image? How do you feel about your body? Are you trying to lose weight? Have you ever felt you needed to lose weight? And often patients will open the door to talking about their concerns. What are some clues? Anorexia nervosa, rapid and severe weight loss. So patient develops mononucleosis and loses 4 pounds, then they lose 10 pounds, then they lose 30 pounds. It's not due to mononucleosis, it's due to anorexia nervosa. Patients will often start dieting. As I said, the majority of eating disorders arise in the context of a diet. They'll start calorie counting, they'll look at labels, they'll know the calorie counts, they'll choose lower calorie foods, and eventually they'll cut out what we call risk foods. So patients will start by cutting out junk food and desserts, and then they'll go to cutting out classes of food, white carbohydrates, beef or red meat, to fish, to going to vegetarianism, to going to veganism. Anything that's high calorie or considered unhealthy will often be cut out, so patients will end up with a very restricted food intake. You might see patients increasing their regular exercise to excessively exercising, getting very upset if they can't exercise. I've had patients who run on shin splints and get very upset that they cannot run. I've had orthopedics actually boot some patients because they said, you cannot run and I'm going to put a boot on you so you cannot run. And it can be very distressing to patients. Patients will often spend a large amount of time looking in the mirror, weighing themselves, trying clothes on over and over, a focus on body image and appearance with a dissatisfaction that drives that. And often we'll see patients who have syncope or dizziness, they're getting cold, they're getting tired. I had a patient say, I have chronic fatigue syndrome, and I said, no, you have anorexia nervosa, and it's all going to get better when you recover from that illness. Turning to bulimia nervosa, and this is very key and crucial. With anorexia nervosa, the weight trajectory is of weight loss, then the weight goes up when they go into treatment, and sometimes the weight drifts down or falls again and then they get back into treatment, or hopefully they end up with a stable weight. With bulimia nervosa, because of binging, purging cycles, you end up with weights going up and down. So a patient might start out at 140, go down to 120, go back up to 160, go down to 110, and really strong cycling of weights up and down. Parents might also notice that every time a patient eats, they go to the bathroom to throw up. They might find vomit, laxative boxes, or enema boxes in the trash. Russell's sign is a knuckle abrasion from patients putting their hands down their throat to try to gag themselves, to make themselves vomit. We see parotid and salivary gland swelling. Dentists will notice a loss of dental enamel, and patients will often have symptoms of gastroesophageal reflux disease. And on screening labs, you might notice a low potassium and an elevated bicarb. So when we assess a patient, we want to know what was their height and weight before this started. I often get growth charts. What's their maximum weight? What's their minimum weight? Is there been weight cycling? What's their current weight? And often I ask patients, what do you want your weight to be? And patients are often very upfront. So if I have a patient who's 5'7", whose weight should be somewhere in the 120s, depending on their age, who's at 105, who wants their weight to be 99, you know you have a problem. We then calculate a percentage of ideal body weight, or BMI. Ideal body weight is a misnomer. There's no ideal body weight. Everybody's weight is different. It's actually average body weight. A quick way to calculate that is 100 pounds plus 5 pounds per inch over 5 feet for women. So for example, a 5'7" would be an ideal body weight of 135. For men, it's 106 pounds plus 6 pounds per inch over 5 feet for men. What we know is less than 65% of ideal body weight is associated with increased mortality. So these are the patients who should be on everyone's radar screen for very frequent medical monitoring and a very clear agreement about hospitalization. Less than 75% meets criterion for inpatient level of care. That's coming from the American Psychological Association, set that criterion. And in the DSM-IV, less than 85% meet criteria for anorexia nervosa. DSM-V, of note, does not have a percentage of ideal body weight. It just says a markedly low body weight. And again, BMI, weight in kilograms divided by height in meters squared, less than 17.5 meets criteria for anorexia nervosa. Again, that's in the DSM-IV. DSM-V does not have that, although those of us who've been using the DSM-IV for many years will probably continue with that number. Of note, normal range is anywhere between 20 to 25, so a very wide range of what is considered normal. Here's a pediatric growth curve with the patient's height tracking along at the 50th percentile. Weight was tracking along at the 50th percentile. At puberty, kind of jumped up to 75th, got up into 75th to 90th, and then a really precipitous drop from 165 all the way down to around 90 pounds with the onset of anorexia nervosa. I'm interested in orthostatic vitals. We do a fairly comprehensive laboratory workup in addition to a complete blood count with differential and a comprehensive metabolic profile. We add on magnesium and phosphorus, which are not on most hospital laboratories' comprehensive metabolic profiles. We also check amylase. We screen a TSH, which then kicks to a full TFTs if there's any abnormality in TSH. Creatinine phosphokinase for muscle breakdown, and a drug screen. And we also check an EKG on every patient who's admitted. The physical complications of restricting and malnutrition can be divided into those that are very dangerous, those that are serious, and those that are more nuisance and will go away with refeeding. On the serious side, low-weight patients who are not eating, especially those who are purging, are at high risk for sudden cardiac arrhythmias. In the 10 or so years that I've been at the Klarman Center, checking labs on each and every patient who's admitted, the majority of times that I see low potassium, it's in very low weight patients who are purging, or patients who are abusing laxatives or enemas. Occasionally patients who have bulimia, who are at a normal weight, who are vomiting multiple 20 times a day, I see low potassium. Otherwise, it's usually a very low weight patient who is also purging. And these are the patients that, again, are at risk for sudden cardiac death due to arrhythmias. We also see significant bradycardia. I've admitted a patient who was just medically hospitalized. Her heart rate hit 24 in the inpatient medical service. When she was admitted to us, she was in the mid-30s. Now she's up in the high 40s or low 50s. Significant hypotension, orthostasis, hypothermia. Mitral valve prolapse is a complication to a weakened floppy heart, and CHF is a refeeding syndrome if you refeed patients too quickly. I'll speak about that later. Another serious complication is bone loss, both osteopenia and osteoporosis. I've had a 16-year-old patient who had spinal fractures on bone scan. This is very concerning in the adolescent population. As you know, peak bone mass deposition is ages 13 to 19. You get one chance of forming a strong skeleton, and if patients do not maintain at a healthy weight, a reasonably healthy weight during this time, they will not end up with a strong skeleton. This is complicated by the fact that when you're 14 and you think you're never going to be old and you're omnipotent and nothing bad can happen to you, patients often don't care that they're damaging their bones. However, by the time they hit late adolescence and young adulthood, often many patients are incredibly distressed. I've had young women who come in at the age of 20 with the bone scan and saying, why didn't someone tell me the damage that I was doing to my body? So we try to get young patients out of their eating disorder as quickly as possible to prevent the bone loss that goes along. We also know that significant restricting and malnutrition is a low serotonergic state. There's low metabolites of serotonin in the cerebral spinal fluid of patients who are very low weight. We see a lot of depressive and anxiety symptoms, low energy, fatigue, insomnia, high obsessiveness in patients with anorexia nervosa. We think of it as a low serotonin state, and also one that is often associated with significant suicidality. I'll again speak about that later. But again, a concerning complication of restricting and malnutrition. Other side effects are more nuisance side effects. The dry skin, the lanugo, some refeeding edema, delayed gastric emptying, which makes it hard when patients actually do start eating because food sits in their stomach for longer, the constipation that comes along with malnutrition. Pancytopenia, again, corrects with significant, with weight restoration. A sick euthyroid syndrome, which again corrects with refeeding. Hypoglycemia, because patients don't have a glycogen store. And low LH, FSH, estrogen, and testosterone, which in the adult population can lead to infertility, which is not usually a concern in the adolescent population. What are the physical complications of purging? Again, most medically dangerous is sudden cardiac arrhythmia due to hypokalemia. Patients may also have quite a low heart rate because purging stimulates the vagus nerve. They lose volume due to the purging, and then their heart slows down due to the purging, and they can often get hypotense and have a lot of dizziness, even though their weights are technically fine. On labs, we see low potassium, elevated bicarb, and often elevated salivary amylase as the vomitus causes parotid and salivary gland swelling and releases amylase into the serum. Dentists often pick up on purging because there's a loss of enamel and dental cavities at the back of the mouth. And we often see complications on the GI front, including Mallory-Weiss tears, the most serious, as well as a lot of gastritis and reflux disease, and sometimes dysmotility due to abuse of laxatives that are chronic. Turning now to treatment, perhaps the most important thing in treatment is to triage for the danger zone. So I've had patients who present for medical care to their university health service because they're having a really bad cold, or they have sinusitis or an ear infection, and they get put in the hospital because they're actually in medical danger. In terms of medical danger, very low weight, especially if you're purging, less than 65% is associated with increased mortality. I want to be cautious about looking at the number of the scale and saying, oh, okay, well, they're 75%, they're okay, because patients with eating disorders will often water load. I had one patient who drank water and salt prior to every weigh-in to make her dorm requirements for staying in her dorm. So she would water and salt load to the tune of 11 pounds to make her dorm weigh-in. So the number you see on the scale may or may not be accurate. Even in our unit, we've had patients who pad their weight up to 10 pounds. Other patients will slouch to make it look as if their height is less than it is. So being very careful when you're weighing, usually in a Johnny, and when you're measuring patients, making sure that they're standing up straight. And if they look very, very, very low weight, even if the number tells you differently, they probably are very low weight. Patients who are medically unstable with hypotension, bradycardia, low potassium, phos, mag, and prolonged QTC. Refeeding is a complication of patients who have not been eating, suddenly start eating a large amount of food, can drop their phosphorus and end up in a dangerous refeeding syndrome. When we admit a patient who's low weight, who has not been eating, we start them off gradually on about 1,000 calories a day and then increase it very slowly, at the same time repleting their phosphorus levels, eventually getting to eating 3,500 to 4,500 calories a day, but it's about 2 to 3 week process to get them up to that calorie count. And again, looking at suicidality, we know, unclear whether it's due to comorbid depression, unclear whether it's due to the chronic stress of this illness, unclear whether it's due to low serotonin, that patients with anorexia nervosa particularly have a very high risk of suicide, and so screening for suicidality in these patients is incredibly important. I'm often asked, what level of care do you recommend for this patient? I'm called up and said, can I run a case by you? I have this patient. I'm not sure what level of care they should be treated. So on the left, anorexia guidelines. It's very reasonable to try outpatient care for a patient with anorexia nervosa. However, if you do that, there's usually a team involved with preferably a registered dietitian who's experienced in eating disorders, a pediatrician, a therapist who's experienced in eating disorders, often a family therapist, and sometimes a psychiatrist, with really weekly weigh-ins with a plan to weight restore by ½ pound to 1 pound a week. Doesn't have to be every single week you need to gain weight, but the upward trajectory has to move forward with a plan that after a month or 2 or 3, if one is not able to gain weight, that the patient will be hospitalized to make sure that they know that there is a backup plan if they can't restore weight as an outpatient. If they are medically unstable or have acute suicidality, sometimes patients need to come into the inpatient hospital. If they're unable to gain weight outpatient, often the level of care right now is acute residential, basically sleeping in a hospital, but it's not a locked psychiatric unit, or partial or day hospital where patients come in everywhere from 7 a.m. to 7 p.m., which is what our partial is, or 9 a.m. to 3 p.m., where they have several meals in the program and go home and sleep at night and eat the rest of their evening meals or snacks at home. Bulimia nervosa, on the other hand, is almost always treated outpatient. There's very good evidence-based treatment for the outpatient treatment of bulimia that I'll speak about in a later slide. And patients are usually only going into the inpatient unit if they have acute suicidality or serious medical complications due to bulimia nervosa. Sometimes patients are hospitalized at residential level of care. About 1/3 of the patients at the Klarman Center will have bulimia nervosa and a step down to partial if their symptoms are out of control and they can't get them under control themselves, or if they're complicated by comorbid psychiatric disorders, substance use disorders, suicidality. Those patients often need to be hospitalized as well. Number one goal for treatment of anorexia nervosa is to eat and gain weight to a healthy weight range. We like the eating to be by regular food, sometimes supplemented with Ensure or dietary supplements, but almost always eating regular food and having the patient gain to a healthy weight range. This is as compared to using tube feeding to try to get a patient's weight up to a healthy weight range. What's a healthy weight range? There's actually some dispute about this, but in general, we consider 90 to 95% of ideal body weight as a minimum healthy weight range for adult women, and 95 to 100% for teens. The teens, especially young adolescents or mid-adolescents, often have to get to a higher percentage of ideal body weight to support their pubertal growth. We also want to not just get someone to a healthy weight range, but keep someone in a healthy weight range. So very important to normalize eating, to get patients to restore their ability to eat a variety of food. Not that they're going to eat brownies or chips for every meal, but making it so they can eat brownies, they can eat chips, they can eat French fries, they can eat ice cream, they can eat a variety of foods, and that they're eating a variety of foods without a lot of risk foods or I can't eat this and I can't eat that and these are only my safe food. Greatly improves prognosis for weight maintenance if patients are able to eat a variety of food. And also that they stop compensatory behaviors so that we don't have patients continuing to purge or continuing to compulsively exercise, because often that leads them to relapse on the weight loss. We also want to, at the same time, treat any comorbid conditions, treat stresses, and really give them, in many ways, a heads up on body image. So unfortunately, just getting someone to a healthy weight range does not restore their normal sense of body perception. Patients who are refed to a healthy weight range will very frequently have body image distortion and body image distress. And in many ways, what we ask them to do is to back burner their body image and focus on other areas of their life as they continue to do the right thing and eat enough food to keep themselves outpatient. The reason why we do this is because eventually, if someone is refed for a long enough time, focusing on other things, hopefully body image will improve. Sometimes it even gets better, or it starts mattering less. But we can't expect that the body image will recover as weight restores. It often remains as a very psychologically distressing symptom. In terms of psychopharmacology or psychiatric medications that are helpful for anorexia nervosa, in 2005, the National Institutes of Clinical Evidence looked at all of the evidence base for the treatment of medications for anorexia nervosa. At the same time, the Evidence-Based Practice Center of the University of North Carolina at Chapel Hill looked at the same literature base. Both were published and came out with the same indication that there's little evidence that medications help for anorexia nervosa. We also know that there's no evidence that fluoxetine helps with relapse prevention for anorexia nervosa. There had been a question whether fluoxetine could help prevent relapse, but there was a large study coming out of Columbia and University of Toronto of fluoxetine in weight-restored patients. I think the average dose was 60 milligrams, and there was no difference in the rate of relapse for either group of fluoxetine or placebo. Since that time, there have been many studies on atypical antipsychotics. At first glance, atypical antipsychotics, which are commonly used to treat bipolar and psychotic disorders, should be the perfect medicines for anorexia nervosa. After all, we know that one of the major negative side effects in patients with bipolar and psychotic disorder is unwanted weight gain, probably due to both the combination of increased appetite but also some metabolic changes in body metabolism. And so at first glance, we should say these medications should be what helps to treat anorexia nervosa. There was one study using olanzapine at a day hospital that did have an increased rate of weight gain, another study using risperidone, which did not have an increased rate of weight gain. However, I want to have two cautions. First of all, that getting a patient to a healthy weight gain is very important. However, relapse prevention is in many ways more important. Over 95, maybe even more, % of patients at our hospital get into a healthy weight range without the use of medications, just by eating food. And many patients who are afraid of weight gain are actually afraid to take medications that might cause weight gain. So if you truly consent a patient who has anorexia on taking a medication that can cause weight gain, they're often afraid to take it. That being said, I do use these medications outpatient in certain circumstances, but I use them with a certain amount of caution. The principle of psychopharmacology for anorexia nervosa, again, not to, in general, use medications to treat the primary anorexia nervosa, but definitely to use medications as indicated to treat comorbid depression, comorbid anxiety disorders, sometimes substance use disorders. Often once weight is restored, just because the malnutrition can interfere with the use of the medication and because you get more side effects. Speaking of side effects, perhaps even more important than what medications we use are what medications should we not use in anorexia nervosa, because many medication side effects can be dangerous or problematic. For example, Deseril is a sleep aid which we commonly use in psychiatry, very helpful for insomnia, however can cause orthostatic hypotension. If a patient is low weight, they don't have a lot of cardiac reserve, it can really worsen their dizziness and syncope. Prolonged QTC associated with many atypical antipsychotics is worse in low-weight patients. Psychostimulants used to treat ADHD can further weight loss. Any medications which cause nausea, any medications causing weight loss, for example, topiramate is used to treat migraine headaches, can often further weight loss, or any medications that cause weight gain. Again, patients with anorexia nervosa are afraid of weight gain. If they take a medication, get to a healthy weight, and then continue to gain weight because they're on a medication that causes weight gain, it can often trigger a significant relapse. I'm going to say a word about another evidence-based treatment. The Maudsley method of family therapy is an outpatient method used to keep patients out of the hospital and recover from their eating disorder. The evidence is for children and mainly young adolescents. My caveat is that I don't practice Maudsley in my private practice or at our hospital, and so but this is the treatment of Maudsley that is used for anorexia. First of all, it's a non-blaming approach. Basically, the child is considered separate from their eating disorder, and the family is united around the child to say, we're going to help you recover from their eating disorder. At first, the parents take control of weight restoration. So just like a baby or a toddler or a young child, the parents would be in charge of what the child eats, when they eat. In this case, the child or young adolescent would be sat down and said, this is what you're eating for breakfast, this is what you're eating for lunch, here's your snack, here's your dinner, and they will really kind of get the child to eat without forcing or causing punishment or having a lot of emotional upset about this. As the patient weight restores, they gradually return control to the teenager, and then at a normal weight, you can switch to more addressing other family issues, developmental delays, needs of siblings, family, and focus on relapse prevention. And again, it's an outpatient method that is designed to avoid hospitalization with a large amount of family involvement. Switching now to the treatment guidelines for bulimia nervosa. Again, with bulimia nervosa, these patients are not underweight. They have usually normal or above body weight, but they are distressed and want to lose weight. So the number one treatment goal for a patient with bulimia nervosa is actually to get them to try to stabilize their weight. Patients will come into our hospital and say, I really want to stop binging and purging. And I say, well, how about stopping restricting and trying to lose weight? And they say, no, I want to keep trying to lose weight, but I want to stop binging. And a lot of education has to be done about recovery from bulimia is really about trying to stop losing weight or changing your shape, and in some ways stabilizing your weight, even though body image will not be good, to allow one to recover from bulimia nervosa. To that end, again, we want them to normalize their eating. We want them to eat breakfast, lunch, snack, dinner, snack. We want them to eat a regular amount of food in a regular amount of time without compensatory behaviors of restricting or purging or exercising. And as patients can do this, regular, mindful, planful eating, often their bulimia really gets under control. We also want to treat comorbid conditions, stresses, and body image concerns that are also part of bulimia nervosa. In terms of treatment guidelines, there's very good evidence for cognitive behavioral therapy. The cognitive behavioral therapy that's commonly used is coming from Oxford. Professor Fairburn published a book on the cognitive behavioral therapy of eating disorders. And these methods of cognitive behavioral therapy have evidence both in short and long-term studies, because in CBT we change how people eat, we change how people think. Once they get better from the eating disorder, that tends to be sustained. There's also evidence in the literature that medication, in this case fluoxetine, is the medication that has been tested and has the FDA indication for bulimia nervosa. At higher doses, 60 milligrams work better than 20 milligrams, with a pretty rapid onset in about 2 weeks, can help with binge purge frequency. So very important point. One is the studies lasted up to 16 weeks, and so we don't really know what happens after 16 weeks. Do they help in the long run or do they help in the short run? They do decrease binge purge frequency, and also they don't get the patients necessarily into recovery. So you might take a patient who's binging and purging 5 days a week, and now they're down to binging and purging twice a week. That's a clinically significant improvement, but it is not recovery. So if there's availability for cognitive behavioral therapy, of course that's the way to go, although I often augment and combine both in patients. Here's an example of a binge analysis. This is coming straight from CBT. Binging, is it due to hunger? Because if patients are not eating, especially breakfast and lunch, they don't eat, they get very hungry, they start eating in the afternoon, it triggers a binge. The treatment for that is regular eating. Eating breakfast, eating lunch, eating snack, eating dinner, eating snack, having a regular amount of caloric intake so they don't have excessive hunger. Binging may also be due to breaking food rules. So patients often have lists of foods that they don't eat, foods that they're very anxious about, and when they start eating one of these off-limit foods, it triggers a binge. So I had a patient who every time she ate pizza would binge, otherwise completely avoided pizza, and the treatment was to get her to gradually reintroduce pizza on a small basis once in a while until she could have it as a regular part of her diet without binging on it. So eating a variety of foods helps with binging due to food rules. Binging is often also due to emotion dysregulation. Patients get very upset, and then they turn to binging to help them cope. And in this case, we use a variety of coping skills to really help patients ride the urge to binge, distraction, get away from the kitchen, and really wait until you can go back and eat more mindfully. What happens to eating disorders? In 2008, Steinhausen did a meta-analysis where he looked at large numbers, 119 patient series based on 5,600 patients, and looked at the prognosis. What happens to these patients? His comment was there was so much variability in the study that these numbers can only be taken as trends towards the mean. But in general, what we think is that about half patients recover from anorexia nervosa, about a third improve, 20% go on to have a chronic course of anorexia nervosa, and unfortunately about 5% of patients with anorexia nervosa will die from their illness. He also did a meta-analysis on bulimia, although there was only 24 outcome studies, so much smaller patient series. And again, about half patients improved, about half patients recovered, a quarter improved, a quarter had a chronic condition, and a 0.7% mortality rate. However, in 2009, Scott Crow and colleagues published in the American Journal of Psychiatry a longitudinal review looking at about 1,900 patients over 25 years at an outpatient eating disorder clinic, and they compared these patients using the National Death Index to say who died. And what they found out was that for patients with bulimia, the crude mortality rate in this case was about 4%. Only about 1% died of suicide, so the rest died from medical complications. And EDNOS, which in this series includes subsyndromal anorexia, subsyndromal bulimia, and binge eating disorder, had also a very high crude mortality rate of about 5%, meaning that it's a much more serious bulimia nervosa and eating disorder NOS, which again includes binge eating, and subsyndromal anorexia nervosa and bulimia nervosa are actually still incredibly serious illnesses with significant mortality.